having me. Okay. So again, my name is Lauren Eisenbud. I am a hematologist and oncologist with City of Hope in Simi Valley. I'm glad to be here today to speak with you all. Today I'll be talking about colorectal cancer, the risk factors, prevention, and early detection. So first up, a quick roadmap of what we're going to touch on. So I'll touch on the epidemiology of colorectal cancer, the risk factors for colorectal cancer, as well as the protective factors, signs and symptoms, as well as screening. So what we classify as helping for early detection of colorectal cancer. Starting off with the anatomy, just so we're all in the same place, the same boat. The colon and the rectum are part of our large bowel. As you can see, it starts with this. So our esophagus, which is our feeding tube, connects to our stomach and then our small bowel and then into our large bowel. So our large bowel starts here. If you think about it, kind of the right lower portion of your abdominal cavity with the cecum. It ascends up in the ascending colon to the top right portion of your abdominal cavity, and then it crosses over the transverse colon, down the descending colon on the left side of your abdominal cavity, and then it finishes off as the sigmoid colon. The rectum is, it's part of the large intestine but somewhat of a separate entity just because they are treated very differently from colon cancer. And then the end of our gastrointestinal tract is the anus, which I will not be touching on today. So going into epidemiology of colorectal cancer, this slide is from American Cancer Society. The top is the estimated new cancers in 2023, and the bottom is estimated deaths. As you can see, highlighted in red, colorectal cancer is the third most commonly diagnosed cancer amongst men and women in the United States, projected to be about 150,000 newly diagnosed cases. And it accounts for about 8% of all new diagnoses of cancer. On the bottom, colorectal cancer is also the third most common cause of death amongst cancer patients in terms of cancer diagnoses, and estimated to be about 50,000 new deaths in 2023. And again, kind of similar to the new cases, about 8 or so percent accounts for about 8% of all deaths from cancer. So it is, one of the more common cancers in the United States. Between colon and rectal cancer, colon cancer is much more common. Accounts for about 2/3 of the case. So, they say about 107 cases of colon cancer in 2023 and about 46,000 cases of rectal cancer. It is more common in developed countries. I'll touch on this later, but this is probably because of the, Western diet, processed foods, high fat diet, etc. In the United States, the lifetime risk of developing colorectal cancer is about 4%. It is more common in men than females. Males have about a 33% higher risk of developing colorectal cancer as compared to females. It's also more common in African Americans than white Americans, about 20% higher risk. The good news is the incidence is declining. About 2% annually per year in the United States. Recently, that trend, that growth the incidence has slowed a little bit to about 1.2%, but still the fact that it's declining at all is obviously a very good thing for us. So in terms of the risk factors, the etiology of colorectal cancer is very complex, and we don't have the full story, but there's a lot of different factors at play. So I'll be touching on patient-specific factors, environmental factors, as well as genetic factors. So first up, I'll touch on age. Colorectal cancer is really, really uncommon before the age of 40 years old for the most part. Median age of diagnosis is 69 years old. If you look at this graph on the right, I know it's really small and hard to see, but essentially it's kind of the incidence of diagnoses based on age. And take my word, you can take my word for it, but really the cutoff point where the slope really starts, inclining very quickly is above 50 years old. The problem is although I say it's pretty uncommon in younger people, the incidence for people being diagnosed under 50 years old is increasing pretty rapidly. Some really, rather new data from the past couple of months from the American Cancer Society show that for people under 55 years old that are diagnosed with colorectal cancer, in 1995, they accounted for about 10% of all newly diagnosed colorectal cancer cases. In 2019, that number went up to 20%. So in the span of 25 years, the rate of the percentage of people, younger people being diagnosed with colon cancer has nearly doubled, which is really pretty scary. Amongst these patients, it's more common for them to be diagnosed with rectal cancer than colon cancer. And what is the thinking as to why the higher incidence in the younger patients? The Western diet. So again, I kind of touched on it, and I'm definitely going to touch on it more in the coming slides, but processed foods, high fatty diet, lifestyle. We are an overall sedentary population, and that is a risk for colorectal cancer. Additionally, family history. Studies have shown that for these patients that are younger that are diagnosed with colorectal cancer, about 30% have a family history of a first-degree relative having colorectal cancer. A first-degree relative is either a parent, a sibling, or a child. So these graphs break down the incidence of colorectal cancer over the years based on age. On the left side, this is for patients under 50 years old. Again, it shows what I just spoke, that the incidence is increasing in these patients. The cutoff on these graphs is 2015. So, we still have 8 years of data to add to these graphs, but it would continue to increase. For everybody else, above 50 years old, for the most part, the incidence is decreasing, like I alluded to earlier. So it's really that younger population that we need some more research into what's going on and why the higher rates of colorectal cancer. Additional risk factors, lifestyle. So the obesity epidemic certainly has been shown to increase the risk of colorectal cancer, having a sedentary life as well. And what is the reason for this? They think, our normal gut has a particular what we call microbiome, or composition of different bacterial flora. And the thinking is that a combination of the Western diet along with obesity, it changes that microbiome, and the bacterial flora is less diverse. This can lead to chronic inflammation in the intestines, which ultimately can promote cancer growth, colorectal cancer growth. In terms of the diet, the risk factors for colorectal cancer: fatty foods, red meat, processed meats, so hot dogs, deli meats, all our luncheon meats. Additionally, cooking meats at high temperatures has been thought to be a carcinogen for some time. Things like frying, boiling, grilling the meats. A low fiber diet is a risk for colorectal cancer, as is alcohol use. They say, moderate to heavy, which is classified as 2 or more drinks per day. Additionally, smoking. So, of course, smoking or colorectal cancer is not one of those cancers that we typically link to smoking, or we think about smoking. Usually we think about lung cancer, head and neck cancer, but colorectal cancer is more common in smokers. Primarily, rectal is more common than colon, but a study showed that the risk of developing colorectal cancer is about 50% higher in patients that are current active smokers as compared to people that have never smoked. So that's a pretty dramatic increase. And additionally, for people that are already diagnosed with colorectal cancer, they have worse outcomes if they're smokers. Kind of, along the lines of the other smoking associated cancers, the longer you smoke, the higher risk you have of developing colorectal cancer. Additional risk factors, I know I spoke about this earlier, male predominance, so men are more common, about 33% than female. Ethnicities, American Indians, African Americans have higher risk of developing colorectal cancer as compared to white Americans. Ashkenazi Jewish population additionally is at higher risk. Anybody diagnosed with inflammatory bowel disease, so Crohn's disease, or ulcerative colitis have about a 5 to 10-fold higher risk of developing colorectal cancer. These people have a lot of inflammation in their gut, and that often can increase the process of developing colorectal cancer. The longer somebody has inflammatory bowel disease, the higher the risk of developing the cancer. Additionally, with inflammatory bowel disease, every patient has a different extent of disease in terms of how much of their bowel is involved. So the more bowel that the patient has involved, the higher risk of developing colorectal cancer. Anybody with a personal history of colon cancer has a higher risk of developing a second colon cancer. Studies have shown that if somebody has has colon cancer that is treated, they have about a 1.5 to 3% risk of developing a second independent colon cancer within 5 years. So that definitely puts you at risk for additional colorectal cancer. Additionally, anybody with a history of adenomatous polyps is at increased risk for colon cancer. I'm going to touch on this a little bit later in coming slides. But adenomatous polyps are precancerous polyps. Lastly, patients with type 2 diabetes are at risk for increased risk for colorectal cancer. Part of the thinking is they have similar risk factors. People with type 2 diabetes often are overweight, often have poor diet, often are more sedentary, which are the same risk factors for colorectal cancer. But in addition, type 2 diabetes is a state of insulin resistance. So patients have insulin circulating, but their body is resistant to it. And so the body's compensation is to secrete more insulin. So there's higher levels of insulin and higher levels of a protein called insulin-like growth factor. These they promote proliferation of different cells in the body and as well as tumor cell proliferation. So these patients certainly are at higher risk as well. Family history. Anybody with a family history of colon cancer or colorectal cancer is at higher risk for developing colorectal cancer themselves. Specifically, if somebody has a family history of a colorectal cancer in a first-degree relative, again, that's a parent, sibling, or child. Additional risk factors are if any relative, not necessarily a first-degree relative, but any relative is diagnosed at a young age, or if they have multiple family members diagnosed with colorectal cancer. On the bottom, this chart basically it looks at the risk of developing colorectal cancer based on your family history. On the far left, that first bar is somebody that has no family history of colorectal cancer. And then the second bar to the left is somebody with a first-degree relative with colorectal cancer. And as you can see that the magnitude of increase of risk of colorectal cancer is quite high. Even higher than is if you have a relative that's diagnosed with colorectal cancer at a young age, less than 45 years old, your risk is even higher. And then the highest risk is if you have multiple relatives, so 2 or more relatives diagnosed with colorectal cancer. Again, not necessarily first-degree relatives, but any relatives. So it is very important to know your family history so that you can be aware of your personal risk of developing colorectal cancer. The last risk factor that I'm going to touch on is hereditary colorectal cancer syndromes. we can be born with changes in our DNA or our genes that can increase our risk for developing certain types of cancers. And there's various syndromes, and depending on the genetic mutation you have, it's associated with different types of cancers, So we do have a number of cancer syndromes that increase your risk for colorectal cancer. I'm going to touch on the two most common though, because overall they're not very common in the setting of colorectal cancer. Only really accounting for about 5% of all new colorectal cancer diagnoses. The first is Lynch syndrome, also known as hereditary non-polyposis colorectal cancer. Again, overall rare. It's about 3% of all colorectal cancer cases are patients diagnosed with Lynch syndrome. This is a hereditary inherited defect in DNA repair genes. So the name of the genes are MLH1, MSH2, and MSH6. The role of these genes are to repair DNA if the DNA is damaged. So if a cell has damaged DNA, these genes help to repair that so that we can have, the subsequent generations of cells can have healthy genes. If one of our genes is mutated and we can't repair the DNA, the damaged DNA, then we're at risk for replicating abnormal cells, which subsequently increases the risk for developing cancer. Patients with Lynch syndrome do have an earlier diagnosis, typically an earlier age of diagnosis of colorectal cancer, about 48 years old. And patients are at risk for other types of cancer, primarily endometrial cancer, but a number of others, including ovarian cancer, stomach, small bowel, bile duct, breast cancer, prostate, kidney, ureters, which is the connection between the kidney and the bladder, and then brain. So, it can certainly have, anybody with Lynch syndrome is certainly at risk for quite a number of cancers. The second cancer syndrome I'm going to touch on is familial adenomatous polyposis, or FAP. Even less common than Lynch syndrome, and accounts for about 1% of all colorectal cases. It's an inherited, it's a defect in the APC gene, which is a tumor suppressor gene. So when it's mutated or turned off, it promotes growth of abnormal cells and thus tumor cells. Typically, this is inherited, but they found that about 25% of cases, patients can have this mutation with no family history whatsoever. So they think it's kind of a new mutation that arises in these patients. Patients with familial adenomatous polyposis typically have hundreds of polyps when they go in on or these precancerous growths in the colon when they go in on a colonoscopy, and these are at risk for developing colon cancer. The age of onset is very, very young. About 90% of patients will develop colorectal cancer by 45 years old, but often they're diagnosed, late teens, early 20s, so really quite young. People with this cancer syndrome are at risk for stomach cancer, small intestine cancer, pancreatic, and liver cancer. Anybody with this diagnosis, the recommendation is to have their colon completely removed to reduce the risk of developing cancer. And moving on to protective factors for colorectal cancer. So the opposite of what we saw in risk factors, physical activity, being active, having an active lifestyle is very important in reducing your risk. Having a healthy diet, lots of fruits and vegetables, lots of fiber has been shown to reduce the risk of developing colorectal cancer. One study showed that compared with non-vegetarians, a vegetarian diet was associated with a lower risk of colorectal cancer. Women that have taken hormone replacement therapy often have been shown to have a lower risk of developing colorectal cancer later on. That being said, I'm certainly not advocating for everyone to go on hormone replacement therapy. There are a number of potential issues that come about from that, including cardiovascular risk of breast cancer, but just, something to consider. And then likewise, one study showed that women that took oral contraceptives or birth control pills also had a lower risk of colorectal cancer. Anybody that has long-term use of aspirin and other non-steroidal anti-inflammatories like celecoxib have been shown to have a lower rate of colorectal cancer. That being said, most of the studies were done in patients that already had a diagnosis of colon cancer, and then after which they were started on aspirin, and then they were shown to have a lower risk of developing secondary polyps and cancers. But still kind of pretty convincing data, and I know that there's a lot of people that try to take aspirin for this reason. Calcium use additionally has been associated with a lower risk of developing colorectal cancer. The American College of Gastroenterology actually recommends calcium supplementation for prevention of these of the polyps, the precancerous growth. Very little downside to calcium for the most part. So I don't think it hurts to take calcium. Then there's some other protective factors that have a lot of conflicting data, where some studies have shown they're protective, some studies have shown they have no benefit. These include dairy products, vitamin D, magnesium, folic acid, statins, which are commonly used to lower your cholesterol, and bisphosphonates, which are used to improve bone density. Okay, moving on from risk factors, and I'm going to talk about signs and symptoms of colorectal cancer. Very important to be aware of these, so that if if anybody has any of these symptoms that are persistent, that they certainly seek medical attention. So early stage cancers often are asymptomatic, unfortunately, and that's why we'll talk about screening is so important. But about 3/4 of patients present with change in bowel habits. The patient will say, oh yeah, I actually did have new diarrhea that was out of the ordinary, or new constipation for me, or the way my stool looked was different. Often patients will say that it's like pencil thin, so much thinner than normal, rather than kind of having the bulky stool. About half of patients endorse rectal bleeding. You can also palpate masses. So mainly patients with rectal cancer, they may just notice a rectal mass. About 1/4 of patients, or about 12% of patients with colon cancer, will say, oh yeah, I have this abdominal mass that I've noted. A lot of these colorectal cancers are associated with bleeding, which can lead to iron deficiency anemia. So about 10% of cases are associated with that. And, anytime somebody presents with iron deficiency anemia, they certainly should have a workup, a gastroenterology workup, to look for any sign of bleeding, including colorectal cancers. And then, not very common, but about 4% of patients say that they have abdominal pain or just vague discomfort. Additional signs and symptoms, rectal pain. These are patients with rectal cancer. Abdominal bloating. If it's a little bit, if the cancer is very large and is obstructing the lumen of the gastrointestinal tract, patients can present with nausea and vomiting. Other non-specific symptoms like weakness, fatigue, poor appetite, unintentional weight loss. If the cancer has unfortunately spread to the liver, your liver could be big, or you could have jaundice, which is a buildup of bilirubin, so your skin and eyes would look yellow. So a lot of these, they can be very non-specific, especially the bloating, because, I feel like a lot of us will eat something and then we'll feel bloated, and we just kind of attribute bloating to eating. But again, if it's a persistent symptom, certainly don't just write it off and chalk it up to diet changes or something. Okay, moving on, how does colorectal cancer develop? So really, in general, cancer is the uncontrolled abnormal growth of cells. For colorectal cancer, it's the growth of cells in the inner wall of the colon and rectum. And what happens is, in a normal cells, they have a normal pattern of replicating, where one cell will give rise to 2 cells and so forth. But in the setting of cancer, the normal cell can acquire changes in their DNA or genes, and this can cause them to grow abnormally over and over and over again. And thus you get an accumulation of these abnormal cells, and thus cancer. In particular for colorectal cancer, most start as in the inner lining of the colon and rectum as an abnormal growth of tissue, which is called a polyp. They're kind of like little mushrooms. You can think about it like a mushroom. It has like a little bulbous end with a stalk that's attached to the wall of the colon and rectum. These polyps can develop into cancer over 10 to 15 years. We have different types of polyps. We have polyps that do not increase risk for cancer. These are hyperplastic polyps and inflammatory polyps. And these are the most common type of polyps that you'll find on a colon when a gastroenterologist goes in for a colonoscopy. And there's no risk of developing cancer. That being said, if they're larger, over 1 centimeter, they may recommend that you increase your risk for screening in terms of how often you have a colonoscopy or whatnot. We have adenomatous polyps, also known as adenomas, and this is a precancerous condition. We have different types of adenomas. We have tubular adenomas, villus, and then tubulovillus adenomas. And all of these confer different risks of colon cancer or colorectal cancer. Additionally, we have sessile serrated and then traditional serrated polyps, which again increase the risk for colon cancer. So, the adenomas and these sessile serrated polyps are precancerous conditions. Once the cancer develops in the lining of the colon or rectum, it starts to spread through the wall. So through the wall of the colon and rectum, and then can spread, to lymph nodes and unfortunately to distant organs with time. All right. Moving on to screening. So what are the benefits of screening for colon cancer? So number one is to detect and eliminate precancerous lesions. These are the polyps. So you go in, you get rid of these polyps. Again, these polyps are precancerous, so you're reducing the risk of cancer formation. The second reason for screening, is to detect cancers at an early stage. Every cancer has different stages. So, for colorectal cancer, it could be localized to the colon or rectum, and that's considered an early stage. And that's important because these are the cancers that have the highest rate of cure. If once they spread to the lymph nodes, that's regional disease, they don't do as well. And then certainly if they spread to other organs, the prognosis is even worse. So our goal with screening is to detect these lesions early to give patients better outcomes. On the table at the bottom, what it shows, so about a third of patients are diagnosed with colorectal cancer when it's localized just to the colon or rectum. Again, very good prognosis. About 90% of patients are alive at 5 years. About a third of patients are diagnosed with the cancer has already spread to the lymph nodes, and the prognosis is not as good. About 72% of patients are alive at 5 years. And then about 15% of patients, so luckily not a high number, are diagnosed, unfortunately, when the cancer has already spread to distant organs. And naturally, the prognosis is much worse, and it's about a 13% chance of being alive at 5 years. So again, importance of diagnosing these patients early, which is why we do screening. And lastly, I know I touched on this, again, improves outcomes. The earlier that we are able to diagnose these patients, the higher the likelihood that they will be cured. On the graph at the bottom, this shows the mortality rate from colorectal cancer over time. The different lines are different age groups, but essentially it's showing that for the most part, the mortality rate is dropping. So patients are being diagnosed earlier. And thus better outcomes. That being said, American Cancer Society, they recently published some data showing that in the mid-2000s, about 52% of patients were diagnosed with we call advanced disease. So either the cancer has already spread to the lymph nodes or unfortunately to the distant organs. That number by 2019 increased all the way up to 60%. So clearly, unfortunately, for whatever reason, these patients are, recently we have been diagnosing patients later, at later stages. So again, going back to, we need to be screening for colorectal cancer on a regular basis. How do we screen for colorectal cancer? So we have multiple ways. It's not just the classic colonoscopy that we think about and everyone dreads. The first type of screening is direct examination. So we do have our colonoscopy. This is kind of the gold standard for diagnosing colorectal cancer. It's the most accurate diagnostic test also for not just cancers, but also detecting polyps, those precancerous lesions. And that's because you visualize the entire bowel, all the way from the rectum, all the way, descending colon, transverse colon, ascending colon, cecum. You can visualize it all. And then in addition to visualizing it and seeing if there's any abnormalities, you can also either biopsy the lesion at the same time, or you can remove the polyps, the precancerous lesions. Downsides, you require bowel preparation, sedation. It's not a fun procedure, so I'm sure everyone can attest to that's had one. Like any test, it's not perfect. Studies suggest that for asymptomatic patients, the risk of missing a colorectal cancer on a colonoscopy is about 2 to 6%. So overall, very low, but again, it's not a perfect test. And in general, a colonoscopy is recommended every 10 years. Additionally, you can do a flexible sigmoidoscopy. The difference, you can see this on the bottom right on the diagram. So a colonoscopy, again, you visualize the entirety of the colon. With a flexible sigmoidoscopy, you can only visualize the lower portion of the colon and the rectum. So you see the rectum, the sigmoid colon, and the descending colon, but you don't go as far to see the transverse and ascending colon, which is obviously a risk in missing cancers and adenomas in that section, in those areas. Like colonoscopy requires bowel preparation and sedation. And then in terms of how often you do it, it kind of depends. Typically, flexible sigmoidoscopies are paired with additional tests, which we'll talk about in a second, but every 5 to 10 years is the recommendation for the flexible sigmoidoscopy. Lastly, your physician can do a digital rectal exam. And this really is just able to palpate the very lower portion of the GI tract, so the anus and the rectum. Additionally, we have imaging to diagnose, to detect abnormalities in the colon. And this is the computed tomography colonography, or CT colonography, or the virtual colonoscopy. Basically, it's a CT scan of the colon, kind of like the flexible sigmoidoscopy and colonoscopy. You require bowel preparation and sedation, but it's able to kind of detect filling defects in the lumen of the colon. So if you see on the right, the arrow is pointing to a little spot that doesn't seem, your colon should just be gas filled, which will be black on a CT scan. So if you see any changes from that, that could be something abnormal. So here in this case, it's pointing to probably a little polyp possibly. The downside to this virtual colonoscopy is it has a lower limit of detection. So it really can't detect any very small polyps under 6 millimeters. And if somebody chooses to do the virtual colonoscopy, the recommendation is to do it every 5 years. All right, the next screening tool we have is stool-based tests. This is basically looking at the stool. So what is important to know is that if anybody has a positive, an abnormal result from one of these, they will require a colonoscopy. The plus side is these are very convenient. You can do them in in your own home, because all you have to do is collect your stool. You don't have to do any bowel preparation. You don't have to go into an outpatient surgery center. You don't need sedation. You don't have to take time off of work. So very convenient. We have 3 different types, really from left to right. It's not quite as good to the best on the right. So the first we have is the guaiac-based fecal occult blood test. And essentially what this does is it looks for hemoglobin or red blood cells in our stool. Again, a lot of these cancers present with bleeding or kind of a slow bleed from the cancer. And so you can often, you can detect that in the stool. You need to submit 3 different stool samples, so not ideal. It's again, not disadvantages. It's not quite as good as the other 2 I'm going to discuss. And, there's many early stage tumors that don't bleed. And so you could have a false negative, so a negative test, but you could still have cancer. If you do choose to do the fecal occult blood fecal occult, it would be done on an annual basis. The next one is the fecal immunochemical test, or FIT. It's a little bit more advanced than the fecal occult. It also looks to detect the red blood cells in stool, but it's a little bit more specific because it uses an antibody to detect a protein on the surface of red blood cells. So it's a little, it has a higher detection rate for hemoglobin. It only needs 1 stool sample. It's not very good at detecting adenomas or the precancerous lesions. And again, like with the fecal occult, many early stage tumors don't bleed. If you are going to do this, it would be done on an annual basis as well. The last stool-based test is the multi-target stool DNA testing, or what's commercially known as Cologuard, which I'm sure a lot of people have heard of. This does detect blood just like the other 2, but in addition, it detects tumor DNA, so the tumor DNA that is shed off from the tumor, and other biomarkers of cancer. So it has a lot of more components and is a lot more specific at detecting cancer. Like the FIT test, you only require 1 stool sample. It does need to be a full stool sample, so not just a little bit, and it is a little bit more expensive than the other ones. Frequency, it depends. Most agencies recommend every 3 years, but there are, you can also sometimes recommend it on an annual basis. So that's how we screen patients. So how should we go about it, and how often do we screen patients? So these are recommendations for the average risk population. So these are people that have no family history of colorectal cancer. They have no personal history of colorectal cancer or those high risk polyps that are precancerous. You don't have a risk of you don't have inflammatory bowel disease or any hereditary colorectal cancer syndromes. And additionally, no radiation to the abdominal area, because I didn't mention it, but that can also increase your risk for colorectal cancer. So for these patients, according to the American Cancer Society and the USPSTF, the recommendation is to start colorectal cancer screening at 45 years old. This is a rather new update. I think it was at 2021 that they lowered the age of the recommended age from 50 to 45. So that was a big change. They recommend continue screening until 75 years old, assuming life expectancy is at least 10 years. And then for anybody older, in the 76 to 85-year-old range, you can consider continuing screening, but it depends on how healthy the patient is. Does the patient want it? And then there's screening history. So if somebody has a precancerous lesion, you may be more inclined to screen this population. And they say over 85, do not screen anymore. So for this average risk population, the options for screening are you can do a colonoscopy every 10 years. And, if there's changes on the colonoscopy, if they're the polyps or, the adenomas that are found, often you have to have colonoscopies more often. But in general, if you're average risk with a normal colonoscopy, it would be done every 10 years. You could do a flexible sigmoidoscopy every 10 years, along with one of the FIT, which is the fecal stool test. You could just do a flexible sigmoidoscopy every 5 years. You could do the virtual colonoscopy every, I think this may be a typo, I'm sorry, it should be every 5 years. You could do the multi-target stool DNA or the Cologuard every 1 to 3 years, or you can do an annual fecal occult or fit stool test. So again, a lot of options. It's not just the colonoscopy that we always had to do. So a lot of really great options for screening for colorectal cancer. For the high-risk populations, how do we screen for them? So if you have family history risk of colorectal cancer, the recommendation is to either screen at 40 years old or 10 years younger than the age of diagnosis of the colorectal cancer. So if you have a first-degree relative that was diagnosed with colorectal cancer at 45 years old, the recommendation is that you should start screening at 35 years old. If you have inflammatory bowel disease, you should begin screening about 8 to 10 years after first diagnosis. If you have familial adenomatous polyposis, much earlier, you start screening when you're, an adolescent, 10 to 15 years old. And then for Lynch syndrome, recommendation is to start 20 to 25 years old, or, a few years prior to the earliest age of colorectal cancer diagnosis in the family. So what are my take-home points? Know your body, know what's normal for you. If you have any persistent symptoms that are abnormal, I'm not for a day, but 2 weeks or so, certainly bring it up with your provider. Lead a healthy lifestyle, everything that we've been taught to do. Healthy diet, exercise, limiting alcohol, avoiding smoking. Very important to know your family history. Bring it up with your provider. If you feel like you have a lot of cancers in your family, talk to them about it. You can always do genetic testing, but particular for colorectal cancer, it can change how you're screening for colorectal cancer. So very important to document your family history. Again, the importance of screening for colorectal cancer is to remove those precancerous growths, which can cause cancer. So we're helping to reduce the risk of cancer. And again, assuming average risk, start your screening at 45 years old. All right, thank you so much. Any questions?